So the next question, if you see, left atrial dilatation on the X-ray chest is characterized by which of the following? Straight left heart border, rounding of the left heart border, double cardiac shadow, widening of the angle of carina. So select the correct answer using the code given below. So you will have straight left heart border. That is a correct statement. And rounding of the left heart border will not be there. And you will have double cardiac shadow, that is because of the left atrial enlargement, and this will be there on the right parasternal line. Okay, so on the right parasternal line you will have a double cardiac shadow, and then there will be widening of the angle of the carina. So what is the correct statement here? That is 1, 3, 4 is a correct statement. Let me show you the X-ray. So basically, where is that you will have left atrial dilatation and straightening of the left heart border. You will observe this in patients with the mitral stenosis. In mitral stenosis, you will have this. Now, this will be the chest X-ray. That is a normal chest X-ray. So, if you take the normal chest X-ray, it is the left heart border, it will not be straight. You have the presence of the aortic notch. But whenever there is left atrial enlargement, right, you will have the presence of the straight left heart border. You will have the presence of the straight left heart border. Okay, and then not only that, you will also have the double cardiac shadow. You will have the double cardiac shadow where that is in the right parasternal line. So this will be the left atrium and this is the right atrial enlargement, right? Now, in patients with mitral stenosis, this will be the chest X-ray finding. And another important chest X-ray finding is the pulmonary artery. If you observe the pulmonary artery, these patients will have pulmonary artery hypertension, and thereby you will notice that there is enlarged pulmonary artery. Then next important is the 2D echo. In case of 2D echo, the 2D echo is considered as the first line investigation in patients with the mitral stenosis. So in the 2D echo, what is that you will observe is you will have the presence of what is called as the hockey stick sign. And this is what is nothing but the hockey stick, right? Where the individual will have a restricted anterior mitral leaflet mobility. Then how is that you will be able to assess the severity of the mitral stenosis is based on the valve area. So like how do we classify the mitral stenosis? Is one is mild, then we have severe mitral stenosis, and then very severe mitral stenosis. So if you take the valve area in mild, it is 1.5 to 2 centimeter square, whereas in severe the valve area is 1 to 1.5, and in very severe the valve area is less than 1 centimeter square. And if you take the gradient across the mitral valve, in case of mild the gradient is less than 5, whereas in severe the gradient is 5 to 10 millimeters of mercury, whereas in very severe the gradient is more than 10 millimeters of mercury. Whereas you take pulmonary artery pressure, the normal value is around 15 to 20 millimeters of mercury, whereas in mild the pulmonary artery pressure is less than 30, whereas in severe the pulmonary artery pressure is 30 to 50, whereas in very severe the pulmonary artery pressure is more than 50 millimeters of mercury. So this is how you will diagnose the patients with the mitral stenosis. And when you do an ECG in patients with mitral stenosis, you will have what is called P mitral, right, where the P wave it is of M shape, right, where the P wave it is of the M-shaped P wave. That is what is called P mitral. And what will be the duration of the P wave? The duration of the P wave, it will be more than, see, normal duration of the P wave is less than 120 milliseconds. But here in case of P mitral, the duration of the P wave, it is more than 120 milliseconds. Okay, so that is how the ECG in patients with the mitral stenosis will be, right? Then how is that you will treat the patients with the mitral stenosis? So if you see the treatment of the mitral stenosis, in case of mild mitral stenosis, right, these patients will develop only exertional dyspnea, but whereas in moderate and severe form of mitral stenosis, there will be development of the pulmonary edema. And whenever there is development of pulmonary edema, what is that you need to give is, you need to give diuretics. And along with diuretics, these patients will also require the supplementation of the beta blockers, right? And when there is very severe mitral stenosis where the valve area is less than 1 centimeter square, that is the point when you need to do the intervention, that is PBMV, that is percutaneous balloon mitral valvotomy. So PBMV has to be done, right? Whereas now this PBMV, it has certain contraindications. What are the contraindications? If there is like calcific mitral stenosis, you should not do PBMV, right? And as well as if there is presence of the left atrial myxoma, the PBMV should not be done. Now in these two situations, in calcific mitral stenosis and as well as in cases of left atrial myxoma, in these patients you need to do mitral valve replacement has to be done. Right, mitral valve replacement has to be done. So this is about the treatment of the mitral stenosis, right? Next question. We have a 30-year-old male is being evaluated for shortness of breath. On examination, the JVP, it is increased and there is rise in JVP on inspiration. Which of the following is the most likely to be diagnosed? The options are constrictive pericarditis, atrial septal defect, aortic regurgitation, severe mitral stenosis. So among the options which has been given to you, the condition where the JVP increases, that too on inspiration, is nothing but constrictive pericarditis. And what exactly is this particular sign? This particular sign is nothing but the Kussmaul sign. Now let me just do a quick recap of this topic of the constrictive pericarditis. Now what is the most common cause for the constrictive pericarditis is, it is the sequelae of the pyopericardium. Right, sequelae of the pyopericardium is the most common cause for constrictive pericarditis. And what are the other causes for constrictive pericarditis? That includes tuberculosis, trauma, mediastinal irradiation, histoplasmosis, and connective tissue disorders like rheumatoid arthritis, and then systemic lupus erythematosus, and even including the chronic renal failure. What exactly is the pathophysiology in patients with the constrictive pericarditis is, there will be diastolic dysfunction. Right, there will be diastolic dysfunction. What will be the clinical features? They'll have the clinical features of both right heart failure and as well as the left heart failure. Now what will be the features of right heart failure? There will be raised JVP, tender hepatomegaly, there will be pedal edema, there will be portal hypertension, ascites, splenomegaly. These are all the features of right heart failure. Now what will be the features of the left heart failure? The features of the left heart failure, that includes the exertional dyspnea, they will have orthopnea, they'll have paroxysmal nocturnal dyspnea, right? And in patients with left heart failure, they will also have bilateral basal crepitations, that is because of the pulmonary edema. And you will have left ventricular third heart sound. That is what you will observe in left heart failure. And JVP, it is elevated in patients with the constrictive pericarditis. And in patients with constrictive pericarditis, you have accentuated X and as well as Y wave, and you also have the presence of Kussmaul sign. And in auscultation in patients with constrictive pericarditis, along with first and second heart sound, you also have an additional sound, and that additional sound is the pericardial knock. And this pericardial knock, it is a diastolic sound. And X-ray, it will show you the presence of the pericardial calcification, and the 2D echo will demonstrate the presence of the septal bounce, right? And ECG will show you that there is low voltage complexes. Now what is the criteria for low voltage complexes? That is the QRS complex voltage, it should be less than 10 mm in the ventricular leads, that is V1 to V6, and QRS complex, it should be less than 5 mm in the limb leads, that is L1, L2 and L3. And the CT and MRI is the one which will demonstrate the thickness of the pericardium. And how much should be the thickness of the pericardium in CT or MRI is more than 4 mm. And how is that you treat these patients is, we need to give diuretics that will reduce the pulmonary edema and as well as the edema in the systemic circulation, right? Now in refractory cases, you need to do stripping of the pericardium, right? You need to do pericardiectomy. Right, you need to do pericardiectomy. So this is what is your constrictive pericarditis, right? And in patients with constrictive pericarditis, whenever you do this cardiac catheterization, right? So cardiac catheterization will show you the, right? Cardiac catheterization will show you the presence of the square root sign, right? The presence of the square root sign. Now what does the square root sign indicates? It indicates the pressures within the ventricle, right? So during the diastole, you have drop in the pressure within the ventricle, so you have a dip. Now after the diastole, right, whenever there is ventricular diastole, the blood from the atria, it will gush into the ventricle, and the pressure within the ventricle, it increases, and thereby you have elevation. Because the pericardium is like thick, calcified, complete relaxation of the ventricle does not occur. The pressure which was elevated, that will remain static, and that is what is called as the plateau phase. Okay, so this is about your constrictive pericarditis, and you can observe this is the pericardium in case of constrictive pericarditis, where the thickness of the pericardium, it is increased to more than 4 mm, right? And in patients with constrictive pericarditis, you can observe the low voltage complexes. Then followed by that, you can observe the presence of the pericardial calcification, right? So this is the lateral view of the chest X-ray showing the pericardial calcification in case of constrictive pericarditis. And this is the 2D echo where you will have the septal bounce. Now what do you understand this by septal bounce is, during inspiration the interventricular septum will be shifted onto the left side, and during expiration the interventricular septum will be shifted onto the right side, and this is what is called as the septal bounce. And this is the imaging, right, where you have the demonstration of the thickness of the pericardium, and how much should that be? That should be more than 4 mm, right? So that is about the story related to constrictive pericarditis. The next question, we have a 24-year-old man presents with the acute onset shortness of breath with the precordial chest pain. ECG reveals the ST elevation with upward concavity and PR segment depression in lead V2 to V6 and reciprocal changes in the lead AVR. What do you think is the most likely diagnosis? The options are anterior wall MI, acute pericarditis, anterior wall aneurysm, and then aortic dissection. So just now we were discussing about the ST segment elevation, that it is not just present only in STEMI, multiple other conditions you have ST segment elevation. So the answer here is the acute pericarditis. First the concave ST segment elevation in all the leads, right, with reciprocal ST segment depression in the AVR, and all, as well as the PR segment depression in all the leads except PR segment elevation in AVR, that is very much suggestive of acute pericarditis. I'll be showing that ECG as well, right? In anterior wall MI, you will have the ST segment elevation from in V1 to V4, whereas in anterior wall aneurysm, you will have dome-shaped ST segment elevation, right? You will have dome-shaped ST segment elevation. And in aortic dissection, only when the aortic dissection progresses to the coronary artery. So whenever there is coronary artery dissection, right? So whenever there is the coronary artery dissection, that can cause the anterior wall MI, right? Or whichever the vessel the dissection progresses, either it can be an anterior wall MI or it can be a RV MI also if the dissection progresses to the right coronary artery. And accordingly, you will have the ECG changes. Now, let me first tell you about few important points related to acute pericarditis. So, this will be the ECG in case of acute pericarditis, where you have the concave ST segment elevation in majority of the leads, right? In majority of the leads, you have the concave ST segment elevation, but in AVR you have ST segment depression. Then you take the PR segment. So PR segment, it is depressed, right? The PR segment, it is depressed in almost all the leads except in AVR you have the PR segment elevation. This is very much suggestive of acute pericarditis. So what is the most common cause for acute pericarditis? Actually, we exactly don't know what exactly is the cause. It is idiopathic. But among the known etiologies, right, among the known etiologies, it is the viruses which will be causing the acute pericarditis, and the most common virus will be the Coxsackie virus, that is Coxsackie A and as well as Coxsackie B, followed by that ecovirus. And the other infections, the bacterial infections, that includes Streptococcus pneumonia and as well as the Staphylococcus aureus. These are the infections, and next is tuberculosis. These are all the infections which will be causing pericarditis. Then what is the triad in case of the acute pericarditis? The triad in case of acute pericarditis, that includes chest pain, right, and that too a pleuritic type of chest pain, and there will be pericardial rub on auscultation, and ECG will show you that there is presence of the ST segment elevation. And just now we have discussed about the ECG, what will be there. And in case of the 2D echo, these patients with acute pericarditis, they can develop the complications like pericardial effusion. So there can be a thin rim of fluid within the pericardial space. then how is that you will treat? You need to treat the underlying cause, and these patients will be requiring the anti-inflammatory drugs. And these anti-inflammatory drugs include the non-steroidal anti-inflammatory drugs, right? And non-steroidal anti-inflammatory drugs. And if there is recurrent acute pericarditis, then you need to give steroids. Right? If there is recurrence, then you need to give steroids. Okay. Then what are the complications that are associated with acute pericarditis is, these patients, they can develop the pericardial effusion. Right? These patients, they can develop constrictive pericarditis. These patients, when there is recurrent constrictive pericarditis, they can develop the atrial arrhythmias. Right, they can develop atrial arrhythmias. So these are the complications which are associated with acute pericarditis. So this is about the discussion related to acute pericarditis, and this is the ECG of the first option, that is anterior wall MI, where you have ST segment elevation from V1 to V4, and there will be reciprocal changes in the opposite leads where you have ST segment depression in lead 3, right? Then followed by that, you see this aneurysm. In cases of the ventricular aneurysm, you will have a dome-shaped ST segment elevation, right? You will have a dome-shaped ST segment elevation, and this will be permanent, okay? Then the other option like what we had was aortic dissection. Let me discuss few points related to aortic dissection. What exactly is the definition of the aortic dissection? The definition is that there will be a tear within the intima. So there will be intimal tear, and the blood will enter into the planes of the aortic media, right? There will be intimal tear and the blood will enter into the planes of the aortic media, right? Then what is the most common risk factor for the development of the aortic dissection? It is the hypertension. Then what are the other predisposing factors? The other predisposing factors are connective tissue disorders, and these connective tissue disorders include Marfan syndrome and as well as the Ehlers-Danlos syndrome, right? And we also have the inflammatory pathologies like large vessel vasculitis, like Takayasu arthritis, and as well as the giant cell arthritis, okay? And this aortic dissection is also observed during third trimester of the pregnancy, right? During third trimester of the pregnancy. Okay, so these are all the etiologies and as well as the risk factors. Then you need to be very much aware of the classification of the aortic dissection. So we have two important classifications. One is Stanford and as well as DeBakey. Stanford, it is very simple. Stanford type A is that where there is involvement of the ascending aorta and as well as the arch of aorta. And type A, it is considered to be very important emergency. And this is the most common form and it is more dangerous form. These patients, they require emergency surgery. Whereas you take type B where you have the distal lesions, right? Where you have distal lesions. This does not involve the ascending part. So this is the one you will have distal to the left subclavian artery. Okay. And this is not an emergency, right? Then what will be the clinical features in aortic dissection is, so I'll just show you the image. So this is like intimal tear where the blood will enter into the planes of the aortic media. And yeah, so this will be type A dissection where you have ascending and as well as arch involvement. Whereas type B dissection is that where you have the dissection distal to the left subclavian artery, right? Then followed by that, what will be the clinical features? The clinical features is that these patients, they will have chest pain. And this particular chest pain, it is sudden excruciating pain. And this pain, it is a tearing type of pain or ripping type of pain or cutting type of pain. And this particular pain is felt initially anteriorly retrosternal and then it will progress posteriorly in between the two scapular areas. So in the interscapular area, the pain will radiate. Then what are the complications which are associated with the aortic dissection? That includes the cardiac tamponade, right? That can cause, the aortic dissection can cause aortic regurgitation. Aortic dissection can cause myocardial infarction when the dissection progresses into the coronary arteries. And if the dissection progresses into the spinal arteries, these patients will develop the transverse myelitis. So this will be the complications associated with aortic dissection. Then what is the investigation of choice in case of chronic dissections is the MRI. But in acute situations, because of longer time which is taken in MRI, it is very difficult for monitoring in acute situations. So in acute situations, CT iotogram is considered to be the investigation of choice. Then what is the medical management? So the medical management is you need to ensure that the heart rate, it should be reduced, and at the same time the blood pressure also has to be reduced. The heart rate, it has to be reduced to around 100 to 110 beats per minute, and the blood pressure, the systolic blood pressure, you should maintain it between 100 to 120 millimeters of mercury. So what exactly is the drug of choice is the esmolol, right? But which is a short acting, but because of the unavailability of this esmolol, so the alternative drug will be labetalol. So this labetalol, it is both alpha plus beta blocker. So that is considered as the drug of choice, right? And the drugs which are completely contraindicated, that includes diazoxide and as well as hydralazine. These two drugs, they're absolutely contraindicated because these agents, they increase the hydraulic shear and it will propagate the dissection. That is the reason why these two drugs are completely avoided. And which particular type of dissections will require the surgery? So type A dissections, they will be requiring surgical intervention. They will be requiring placement of the graft. They will be requiring placement of the stent. There can be replacement of the aortic valve as well. So this is about the aortic dissection, right? Now, coming on to the next question. So, thickened ventricular wall with normal diastolic function is a feature of hypertrophic cardiomyopathy, restrictive cardiomyopathy, endomyocardial fibrosis, athlete's heart. So please remember, thickened ventricular wall with normal diastolic function, that is what is observed in the athlete's heart. So these patients will have what is called athletic hypertrophy, right? These patients will have what is called athletic hypertrophy. Now let me discuss about the other etiologies. In patients with hypertrophic cardiomyopathy, in hypertrophic cardiomyopathy, you will have the hypertrophy of the ventricular wall, and this particular hypertrophy of the ventricular wall, it should be more than 1.5 centimeters. But these patients, they will have diastolic dysfunction, right? And the hypertrophy, it can be in the septum, causing septal hypertrophy. Whenever there is septal hypertrophy, that will cause obstruction to the left ventricular outflow tract, and that we call it as hypertrophic obstructive cardiomyopathy. And there can be hypertrophy at the apex of the left ventricle, and that is what is called apical hypertrophy. And in case of the septal hypertrophy, what will be the shape of the left ventricle? The shape of the left ventricle, we describe this as the banana shaped left ventricle. Whereas you take in case of apical hypertrophy, in apical hypertrophy, you don't have the obstruction. This we just call it as hypertrophic cardiomyopathy, right? And in case of the apical hypertrophy, what will be the shape of the LV lumen? So the shape of the LV lumen, that is in the form of ace of spades, right? That is in the form of ace of spades. And this development of hypertrophic cardiomyopathy, it is due to gene mutation, right? And what is the gene that is being mutated most commonly? The most common gene that is being mutated is the beta myosin gene, and this beta myosin gene, it is present on chromosome number 14. Then what are the other proteins which are being defective? The other proteins which are being defective are the troponin T, and the other one is myosin binding protein C. These are the proteins which are being defective. Then what type of inheritance is your HOCM? It is autosomal dominant type of inheritance. And there are more than 100 genes which are being mutated, but these 3 genes which are being mutated, they contribute to almost 70 to 80% of all cases of hypertrophic cardiomyopathy. Then if you observe the clinical features, right, please remember, most of the time these individuals, they are asymptomatic, right? Most of the time these individuals, they are asymptomatic, and they directly present with the sudden cardiac death. And if at all, if they are symptomatic, these patients, they will be having dyspnea, right? Along with dyspnea, the other important clinical manifestations these patients can have is palpitations, okay? So dyspnea and as well as palpitations, and they can also have syncopal attack. They will also have syncopal attack. Now, on examination, what is the characteristic pulse? The characteristic pulse will be the pulsus bisferiens. And how will be the carotid? You will notice that there is double carotid upstroke. And how will be the apical impulse? So double carotid upstroke and as well as double apical impulse, right? Double apical impulse, okay? Then what is that you listen on auscultation? Along with S1 and S2, you will also have an additional heart sound, that is S4. And along with that, you have the presence of the ejection systolic murmur, which is also called mid systolic murmur. And the ECG will show you the presence of left ventricular hypertrophy, and you will have deep dagger shaped Q waves. I'll show you that ECG. And the 2D echo will demonstrate that there is hypertrophy, and thickness of the hypertrophy is more than 1.5 centimeters, and you will be able to make out the shape of the LV lumen as well. Now, what is the importance of doing the treadmill test? So please remember, that is, your exercise studies are recommended to assess for ventricular arrhythmias and to document the blood pressure response, right? To document the blood pressure response. Okay. Now the point here is, upon doing the treadmill test, if the systolic blood pressure, upon doing the treadmill test, if the systolic blood pressure, if it does not increase more than 20 millimeters of mercury, right? That means these patients, they are at increased risk of development of the ventricular arrhythmias, and these ventricular arrhythmias include ventricular tachycardia or the ventricular fibrillation. That is about the importance of the treadmill test or the exercise studies. Then what exactly is the drug of choice? That will be beta blockers. And what is the important advice that you need to give is, these patients have to avoid strenuous physical activity, right? And beta blockers are considered as drug of choice, and the alternative drugs will be non-dihydropyridine calcium channel blockers. And surgical treatment these patients will be requiring is, if the medical management is refractory, the surgical management that these patients will be requiring is surgical myomectomy has to be done, right? Surgical myomectomy has to be done, right? And or alcohol septal ablation has to be done. Okay, surgical myomectomy or alcohol septal ablation has to be done. So this is about your HOCM, that is hypertrophic obstructive cardiomyopathy. Done. Now the other option, like, okay, let me show you. Yeah, so this is the scenario where there is septal hypertrophy, and the shape of the left ventricle will be banana shaped left ventricle. And this is the scenario where there is apical hypertrophy, and the shape of the left ventricle will be like ace of spades, and you don't have the obstruction here. And this is the ECG of the hypertrophic obstructive cardiomyopathy, where you have the presence of deep dagger shaped Q waves. Where you have the presence of deep dagger shaped Q waves. Okay. Then the other important option, like what we had, was the restrictive cardiomyopathy. So in case of restrictive cardiomyopathy also, these patients, they will be having diastolic dysfunction. There will be increase in the thickness of the myocardium, and there will be diastolic dysfunction. Then what is the most common cause of restrictive cardiomyopathy is the amyloidosis. So amyloidosis, this is considered to be like the most common cause for restrictive cardiomyopathy. Then apart from that, radiation to the mediastinum. Then another important is myocardial fibrosis. These are all the etiologies that will be causing the restrictive cardiomyopathy. Apart from these, we also have some infiltrative disorders, or we also have some storage disorders. The storage disorder that will be causing restrictive cardiomyopathy will be Fabry's disease, right? So Fabry's disease is what? It is a lysosomal storage disorder. And what is the enzyme that is being deficient? The enzyme that is being deficient is alpha galactosidase A, right? The enzyme which is being deficient is alpha galactosidase A is being deficient, right? And in these patients, because of deficiency of alpha galactosidase A, this will cause buildup of a type of fat that is called globotriosylceramide, right? Globotriosylceramide, which is a lysosomal storage disorder. And pathophysiology is that these patients, they'll be having diastolic dysfunction, and these patients will have the clinical features of right heart failure and as well as left heart failure. But features of right heart failure are more predominant than compared to that of left heart failure, because basically what is the etiology? Infiltrative disorders. Even your hemochromatosis and sarcoidosis and amyloidosis, they are the etiologies. And right ventricular wall, it is like thin than compared to that of left ventricular wall. So the earliest ventricle which gets affected first is right ventricle, then compared to that of left ventricle. So right heart failure features are more common than compared to that of left heart failure features. And on examination, you will notice that the JVP, it is elevated, and you have the X and as well as Y wave being accentuated, and you have the presence of the Kussmaul sign. And these patients, they'll have the functional MR and as well as the functional TR. There will be pansystolic murmur, but that is functional. ECG will show you the presence of the low voltage complexes, because there is thickness of the myocardium, and at the same time, because of infiltration into the myocardium, transmission of the electrical activity to the surface of the chest will be reduced, and thereby these patients will have low voltage complexes, same like constrictive pericarditis. Okay, and what does the 2D echo shows? In patients with amyloidosis, the 2D echo will show you a speckled pattern. Right, the 2D echo will show you the presence of the speckled pattern, which is nothing but you have bright myocardium, right? Bright dotted spots that you will have within the myocardium. And the biopsy, that is endomyocardial biopsy, this is considered as the investigation of choice. So this will help us to make out what is the underlying etiology, right? But this will confirm what is the underlying etiology. Which one? The endomyocardial biopsy, right? Whenever there is systemic involvement of the disease, like in case of amyloidosis, we also take the rectal biopsy, right? We take the rectal biopsy. Okay, then the medical management in patients with the restrictive cardiomyopathy is that you need to give the diuretics, and the treatment will be similar to that of your heart failure. So once the edema and the fluid overload is reduced, then you need to give beta blockers, then you need to give ACE inhibitors or ARBs, and you need to treat the underlying cause. So this will be about the restrictive cardiomyopathy. And these patients with restrictive cardiomyopathy, there is atrial dilatation. The atria are distended, and because the atria are distended, they are at increased risk of development of the atrial fibrillation, and because of which these patients will develop palpitations. And once there is development of atrial fibrillation, these patients will be requiring anticoagulation. These patients will be requiring anticoagulation. And if the sarcoidosis is the cause for the development of restrictive cardiomyopathy, right, if sarcoidosis is the cause for the development of restrictive cardiomyopathy, these patients you need to give steroids. That is, corticosteroids has to be given. So this is about your restrictive cardiomyopathy. Right, now after having discussed about restrictive cardiomyopathy, we will move on to the next question. Yeah, so this is about the low voltage complexes, right? And this is the echocardiography in patients with the restrictive cardiomyopathy, where you can see that atria is distended. Atria is distended, both right atria and as well as left atria is distended. Okay, and anticoagulation has to be given mainly when the patient develops atrial fibrillation, right? Then followed by that, yeah, we'll move on to the next question. In which of the following cases does paradoxical splitting occurs? The options, what do you mean by paradoxical splitting? You take the second heart sound, you have normally A2 and as well as P2. But paradoxical splitting means P2 followed by that A2, right? That is reversible split. So the options are severe aortic stenosis, right bundle branch block, right ventricular pacing, then hypertrophic obstructive cardiomyopathy. So in severe aortic stenosis, you can have P2 then A2. Then you take in patients with the right bundle branch block. In right bundle branch block, you will have A2 followed by that P2, right? In fact, you will have wide split S2. So second option incorrect. Right ventricular pacing, you will have P2 then followed by A2. Hypertrophic obstructive cardiomyopathy. In severe form of hypertrophic obstructive cardiomyopathy, you can have P2 then followed by that A2. So the answer is 1, 3, 4. Like, which option is correct? That is 3. That is 3. Right? Now let me show you. So you see this image, right? In patients with the aortic stenosis, severe aortic stenosis, left ventricle, it will take more time to send the blood into aorta. By the time the right ventricle will send the blood into the pulmonary artery. So thereby you will have P2 followed by that A2. Okay. Then you take right ventricular pacing. So whenever there is right ventricular pacing, in such case, right ventricle will contract first. You will have P2, then followed by that A2. Then in case of severe hypertrophic obstructive cardiomyopathy, left ventricle takes more time to send the blood into the aorta. So thereby by this time, the right ventricle already sends the blood into pulmonary artery, and pulmonary valve also closes. So you will have P2, then followed by that A2. So this is about the reversible split, which we call it as paradoxical split. Now let me just discuss few important points about the aortic stenosis. So when will you call aortic stenosis? So if the aortic valve area, if it is less than 2 centimeters square, this we call it as aortic stenosis. And how much is the normal aortic valve area? Normal aortic valve area is 3 to 4 centimeters square. Now if you take the valve area, how much it should be? Less than 2, right? And if the valve area is 1.5 to 2, mild aortic stenosis. If the valve area is 1 to 1.5, moderate aortic stenosis. If the valve area is less than 1, severe aortic stenosis. And you take the gradient. So the gradient between the left ventricle and aorta, it should increase to more than 10 millimeters of mercury to call it as the aortic stenosis. And then what is the most common cause of aortic stenosis in children? It is bicuspid aortic valve. And what is the most common cause of aortic stenosis in elderly individual will be calcific degeneration of the aortic valve. Then clinical features in these individuals will be angina, then syncopal attack, and as well as dyspnea. So individuals with angina, syncopal attack and dyspnea, that is called as symptomatic aortic stenosis. And in patients with symptomatic aortic stenosis, they definitely require the aortic valve replacement. And on examination, you will have the pulse. It's a low volume pulse. Systolic blood pressure will be reduced, right? And you will have the characteristic pulse, we call it as pulsus parvus et tardus, which is nothing but slow rising pulse with late peaking is what is called pulsus parvus et tardus. And apical impulse, what is that you will have is the heaving type of apical impulse is what you will have. And the murmur, if you observe, it is the ejection systolic murmur, right? And how will be the heart sounds in these individuals? S1 will be normal, but S2 will be soft, right? Why S2 will be soft? Because A2 is soft. That is the reason why your S2 will be soft. And the additional sound that these individuals can have is the S4. Then coming to the Galliverdin phenomena. What is Galliverdin phenomena? Galliverdin phenomena is that the ejection systolic murmur in aortic stenosis, it is best heard in the aortic area, that is in the second right intercostal space, parasternal line. And Galliverdin phenomenon is that the murmur in the aortic area, it is like radiating to the apex, right? It will radiate to the apex, okay? That is what is called Galliverdin phenomena. And ECG will show you that there is presence of left ventricular hypertrophy, which is nothing but a pressure overload condition, right? So you'll have left ventricular hypertrophy. I'll show you that ECG. And 2D echo is the one which will demonstrate the valve area. And just now I have said, so if the valve area is like 1.5 to 2, mild, 1 to 1.5, moderate, less than 1 will be severe aortic stenosis, right? Then you take gradient. The gradient between the left ventricle and aorta, the normal gradient, it will be like less than 5 millimeters of mercury. When the gradient, if it is less than 25, it is called mild aortic stenosis. And if the gradient, if it is in between 25 to 40, it is called moderate aortic stenosis. And if the gradient, if it is more than 40 millimeters of mercury, then we call it as the severe aortic stenosis. Okay. So this is about the 2D echo, which will be able to demonstrate the valve area and as well as the gradient, and you will be able to assess the severity of the aortic stenosis, right? And these patients with the aortic stenosis, they are at increased risk of sudden cardiac death, right? Then coming to the treatment, just now as I have said you, all the patients who are symptomatic, they have to undergo the aortic valve replacement. This aortic valve replacement either by surgical aortic valve replacement or transcatheter aortic valve replacement is what they need to undergo. Okay, so this is about the treatment in patients with the aortic stenosis, right? Now, yeah, so this is the ECG of left ventricular hypertrophy. The criteria that you need to satisfy is the Sokolov-Lyon criteria. So Sokolov-Lyon criteria is that where SV1 plus RV6, right? SV1 plus RV6, it should be more than 35 mm. So this is what is called as the Sokolov-Lyon criteria, suggestive of left ventricular hypertrophy. So that was about the scenario related to the aortic stenosis. Next question. A patient with peripheral edema has the following findings on the clinical examination: a soft systolic murmur at the lower left sternal border with raised JVP showing prominent CV wave. The murmur increases in intensity on deep inspiration, the most likely valvular abnormality. So here the very important clue is the murmur is increasing on deep inspiration. That should be a right-sided valve pathology. So you will see the options: VSD, MR, TR and mitral valve prolapse. So what is the answer? That is tricuspid regurgitation. Now in patients with tricuspid regurgitation, these patients, they will have JVP being increased. Why? Because tricuspid regurgitation is the one which can cause right heart failure, and in patients with right heart failure, JVP is increased. And what are the abnormal waves in the JVP in patients with tricuspid regurgitation? The abnormal waves will be, there will be reversal of the X wave, right? There will be reversal of the X wave. Okay, you don't have the X wave, right? Then you take the V wave. there is increase in the amplitude of the V wave, right? Increase in the amplitude of the V wave. And how will be your Y wave? The Y wave, it is early Y descent, right? You have the presence of the early Y descent. Okay, that is what you will observe in case of tricuspid regurgitation. Now let me discuss all the systolic murmurs. So systolic murmurs are those which are heard between S1 and as well as S2. What are the conditions where you will have early systolic murmurs? You will have that in patients with the acute MR, right? And you will have that in patients with the acute TR. So acute MR and acute TR, you have early systolic murmur. So next is the mid systolic murmur, which is also called the ejection systolic murmur. You will have that in aortic stenosis and as well as the pulmonary stenosis, right? Then you take late systolic murmur, you will have that in patients with mitral valve prolapse syndrome and tricuspid valve prolapse syndrome. Then what are the conditions where you have the presence of the pansystolic murmur? Pansystolic murmur, you have that in MR, TR and as well as the VSD. How is that you will be able to differentiate? The MR murmur, it will increase on expiration and it is heard best in the apex, and this will be radiating to the axilla. That will be your MR murmur. Whereas TR murmur, it will increase on the inspiration. And where is it best heard? It is best heard in the fourth left intercostal space, right? Fourth left intercostal space, the parasternal line, right? Whereas VSD murmur, it does not change with the respiration. Okay, so that is about the systolic murmurs. Okay, now yes, they can sometimes give you image based question. So between S1 and S2, throughout the systole you have the murmur. So this we call it as pansystolic murmur. You can have that in VSD, MR and as well as TR, right? And you see the next image. Yeah, so you have a mid systolic click with late systolic murmur. Now what is that condition where you have a mid systolic click with late systolic murmur? You will have this in patients with the mitral valve prolapse syndrome, right? In MBPS, you'll have this. Then you see another image. Yeah, if you see in this image, you have the peak in the mid part of the systole. You are having a peak in the mid part of the systole. So this we call it as a mid systolic murmur, or we call this as the ejection systolic murmur. Where do you get this? You have this in aortic stenosis. You will have this in case of the pulmonary stenosis, and you will have this in patients with the hypertrophic obstructive cardiomyopathy, right? Then followed by that, the diastolic murmurs. Diastolic murmurs, if you observe, they are the one which are heard between S2 and S1. So diastolic murmurs, we classify them into the early diastolic murmur, that is in AR and as well as the PR. Then you have mid diastolic murmur. You will have mid diastolic murmurs in case of MS and as well as the TS. So these are all the examples of diastolic murmurs. Then coming to the continuous murmurs. Continuous murmurs are the one which are heard throughout the systole and as well as diastole. You have that in patients with PDA, patent ductus arteriosus, which is also called Gibson's murmur. You also have this in patients with the AV fistula, right? So that is in peripheral AV fistula and as well as coronary AV fistula, you have the presence of this continuous murmur, right? Then branched pulmonary artery stenosis. Right, branched pulmonary artery stenosis, you can have the presence of the continuous murmur. And the other condition where you will have the presence of the continuous murmur is in case of mammary souffle. Mammary souffle is that which occurs in pregnancy, right, which occurs in pregnancy. So in pregnancy, due to increased circulation across the internal mammary artery, so whenever you auscultate the internal mammary artery, there will be like the hyperkinetic flow that will give you a murmur, and that is what is called the mammary souffle. And the other condition where you will have continuous murmur is in patients with RSOV, that is ruptured sinus of Valsalva, and this is how the continuous murmur will be. This is how the continuous murmur will be. And please remember, all the right-sided murmurs, they increase on inspiration, and this we call it as the de Carvalho's sign, right? So this we call it as the de Carvalho's sign. Whereas you take all the left-sided murmurs, they increase on the expiration. Okay, so this is about the dynamic auscultation. And one more important thing in the question that we need to discuss is about the waves of the JVP. So in the waves of the JVP, you take A wave that represents the atrial contraction. you take C wave, that is bulging of the cusp into the right atria. Then you take X wave, that is due to atrial relaxation. You take V wave, that is due to venous filling. Right, that is due to venous filling. The superior vena cava and inferior vena cava will drain the blood into the right atrium, causing venous filling. Right, and Y wave, that is due to atrial emptying. Okay, and Kussmaul sign is that where there is increase in the JVP upon inspiration. So atrial contraction, the pressure within the atria increases. C wave, the pressure within the atria increases. X wave, the pressure in the atria decreases. V wave, the pressure in the atria increases, and Y wave, the pressure within the atria decreases, and that is what is nothing but atrial emptying. Now if you take the abnormalities related to the A wave, the conditions where the A wave is absent, that is in patients with the atrial fibrillation. The conditions where you have the giant A wave, that is in tricuspid stenosis, right atrial myxoma, pulmonary stenosis, and then pulmonary hypertension. Right, then you take the conditions where you have Cannon A wave. Cannon A wave, you have that in patients with the complete heart block. You have that in patients with the complete heart block, and you also have this in case of the junctional rhythm. Right, you also have this in case of junctional rhythm. So these are all the A wave abnormalities. Then you take the abnormalities related to the X wave. The conditions where the X wave is accentuated, that is in constrictive pericarditis, restrictive cardiomyopathy, and cardiac tamponade. And what are the conditions where you will have reversal of the X wave, that you will have in tricuspid regurgitation. And the conditions where the V wave is increased, that is in patients with the tricuspid regurgitation. Right, and next is the Y wave abnormalities. If you observe the accentuated Y wave, you have that in patients with constrictive pericarditis and as well as restrictive cardiomyopathy. Absent Y wave, you have this in patients with cardiac tamponade. Slow Y descent, you will have that in tricuspid stenosis. Early Y descent, you have that in patients with the tricuspid regurgitation. So these are all the abnormalities related to your Y wave. So in this particular question, we have discussed about the waves of the JVP and abnormalities, and as well as the various murmurs, right? Now coming on to the next question. Kussmaul sign is a feature of, it's a repeat question actually, constrictive pericarditis, HOCM, anteroseptal MI, dilated cardiomyopathy, right? So in constrictive pericarditis, you have the presence of Kussmaul sign. Now let me just do a quick revision of the dilated cardiomyopathy. So if you take the dilated cardiomyopathy, what is the most common toxin that will be causing dilated cardiomyopathy is the alcohol. And please remember, dilated cardiomyopathy is the disorder where you have dilated chambers with reduced ejection fraction. So it is the one which will cause heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. Right? And what are the drugs that will be causing dilated cardiomyopathy? Includes drug of abuse like cocaine, then adriamycin, then trastuzumab, and then cyclophosphamide. These are all the drugs that will be causing dilated cardiomyopathy. Endocrine disorders where you will have is thyroid disorders and diabetes mellitus, you will have dilated cardiomyopathy. Nutritional deficiencies include thiamine deficiency will cause dilated cardiomyopathy, and selenium deficiency will cause dilated cardiomyopathy. And neurological causes that will be causing dilated cardiomyopathy, that includes the Friedreich's ataxia, and then muscular dystrophies like Duchenne's muscular dystrophy and myotonic dystrophy. Infiltrative disorders are the hemochromatosis. But please remember, hemochromatosis will not only cause dilated cardiomyopathy, it will also cause the restrictive cardiomyopathy as well. The clinical features include the clinical features of both right heart failure and as well as the left heart failure. And on examination, you have a characteristic pulse that is called dichrotic pulse. And on auscultation, you will listen S3 and as well as S4, and these patients, they'll have the functional MR and as well as functional TR. And 2D echo is the one which will demonstrate that ejection fraction is reduced, and these patients, they will have dilated chambers. They'll have dilated chambers. And chest X-ray will show you that there is presence of the cardiomegaly. Right? So cardiomegaly is that where the cardiothoracic ratio will be more than 0.5. Right? How is that you will treat these patients is you need to give diuretics. Right? You need to give diuretics. And these patients with the dilated cardiomyopathy, they will have heart failure with reduced ejection fraction, and you need to give a drug which will improve the ejection fraction, right, and which will reduce the mortality in the individual. So you need to give what is called ARNI, that is angiotensin receptor blocker neprilysin inhibitor. Example include valsartan plus sacubitril. right? Valsartan plus sacubitril. That is what is called as the ARNI, angiotensin receptor blocker, and the neprilysin inhibitor. Then the other drugs that you need to give is the beta blockers. So the drugs which will reduce the mortality, that includes the beta blockers, ARNI, then the ACE inhibitors or angiotensin receptor blockers, then aldosterone antagonist, that is spironolactone, right? And recently the newly added drugs will be SGLT2 inhibitors. So these are the drugs which will reduce the mortality and prevent the progression of the heart failure. And in refractory conditions, they will be requiring the cardiac resynchronization therapy, which is an intervention. So but for doing the cardiac resynchronization therapy, you need to check the QRS complex. It should be wide QRS complex, more than 150 milliseconds if there is left bundle branch block. If there is left bundle branch block is not there, the QRS complex, it should be more than 120 milliseconds. That will be the criteria for doing cardiac resynchronization therapy. And coming to one more important form of dilated cardiomyopathy, that is called peripartum cardiomyopathy, that is development of dilated cardiomyopathy, right? Development of dilated cardiomyopathy in the last month of pregnancy, right? Or within 6 months of delivery. Right, within 6 months of delivery. That is what is called peripartum cardiomyopathy. And what are the risk factors for the development of peripartum cardiomyopathy is elderly females of age more than 30 years, then pregnancy induced hypertension, that is preeclampsia, then multiple gestation. Okay, so elderly females, preeclampsia, and as well as multiple gestation. These are all the risk factors for the development of peripartum cardiomyopathy. And how is that you will treat these patients with the peripartum cardiomyopathy is like same, you need to give diuretics, but you cannot give ACE inhibitors and all. These patients, they will be requiring bromocriptine to be given, because it is the fragments of the prolactin which are being produced in excess quantity during the pregnancy. They are found to be responsible for the development of peripartum cardiomyopathy. You need to suppress the prolactin levels, for which you need to give bromocriptine. So that is about the treatment of peripartum cardiomyopathy, right? So this is about the discussion related to dilated cardiomyopathy. So in dilated cardiomyopathy, you can observe the chambers like they are dilated, okay? And you will have this functional MR and as well as the functional TR. And this is what is your CRT, cardiac resynchronization therapy, where you have 3 leads. One lead is in right atrium, one lead is in the apex of the right ventricle, and the other lead is in the lateral wall of the left ventricle. Okay. Coming on to the next question. A patient has the cardiac murmur that is best heard in the right second intercostal space. It increases with expiration. Also, the murmur reduces in intensity during sustained hand grip, but increases in intensity on inhalation of the nitrate. What is the likely lesion? So, remember, the murmur is heard in the right second intercostal space, increasing on the expiration. Increasing on expiration means definitely it should be some left-sided pathology. Murmur reduces in intensity during the sustained hand grip and increasing in intensity upon inhalation of the amyl nitrate. That is very much suggestive of the hypertrophic obstructive cardiomyopathy. So in hypertrophic obstructive cardiomyopathy, whenever you are giving the amyl nitrate, what will happen to the LV volume? That will be decreased. When LV volume decreases, the obstruction increases. When obstruction increases, the murmur increases, right? Then you take the sustained hand grip, right? And so sustained hand grip is the one which will increase, right, the afterload on the, right, it will increase the afterload on the left ventricle. Once it increases the afterload on the left ventricle, what will happen to the cardiac output? Decreases. Thereby, what will happen to the LV volume? Increases. When LV volume increases, the obstruction decreases. When obstruction decreases, the murmur decreases. So with amyl nitrate, the murmur increases. With sustained hand grip, the murmur decreases. That is what you will observe in case of the HOCM. That is what is nothing but your dynamic auscultation. Now, what are all the drugs which can increase the murmur of the HOCM is? It is not just only nitrates, even diuretics, even digoxin, right? Even the sympathomimetic amines like epinephrine. So these are all the drugs which will increase the intensity of the murmur. Okay. Then the other dynamic auscultations where the intensity of the murmur increases in patients with HOCM is from supine position, the individual is standing, right? From supine position, the individual is standing. So in standing posture, the venous return decreases, LV volume decreases, and the intensity of the murmur increases. So that is what you will observe in case of the HOCM, right? So named murmurs, they are very important part of the discussion. So where is that you have the presence of Carycombe's murmur? You will have that in case of the rheumatic fever, and that is due to acute mitral regurgitation. And Austin Flint murmur, see Carycombe's murmur, Austin Flint murmur, and Graham-Still's murmur. All these are functional murmurs, right? And Austin Flint murmur, if you observe, you listen that in case of the aortic regurgitation, whereas in Graham-Still's murmur, you observe that in case of pulmonary hypertension causing pulmonary regurgitation. And Retan's murmur is observed in case of the complete heart block. Dock's murmur is heard in case of left anterior descending artery stenosis. Millville murmur is the one which is heard in case of the air emboli, right? So these are all the named murmurs, which is also very important part of the discussion. Now, after having discussed about dynamic auscultation and as well as the named murmurs, coming on to the next question. In modified Duke's criteria for infective endocarditis, which one of the following is not the major criteria? So what is the criteria for the infective endocarditis? Is Duke's criteria, right? So in case of the Duke's criteria, right, which one of the following is not the major criteria, right? So new partial dehiscence of the prosthetic valve, it's a major criteria. Positive blood culture, right? So 2 out of 3 cultures should be positive. It's a major criteria. Rod spots, these comes under the minor criteria, right? And the presence of new valvular regurgitation, so this is also the major criteria. So if you take the so if you take the discussion of the major and as well as minor criteria, so in the major criteria, first the cultures, it should be positive, right? How many cultures should be positive? 2 out of 3 cultures should be positive, right? 2 out of 3 cultures should be positive. Then evidence of endocardial involvement, right? Evidence of the endocardial involvement. So how is that you will be able to make out that there is evidence of endocardial involvement? There should be valvular regurgitation, right? Or there should be the abscess formation, right? Or there should be new dehiscence of the prosthetic valve, or there should be new onset valvular regurgitation. So these are all the major criteria. Then what is the minor criteria? Minor criteria, it includes the presence of the predisposing cardiac conditions or the IV drug abuser, right? IV drug abuser. Second important, the presence of the fever, right? Where temperature is more than or equal to 38 degrees centigrade. Then third important is the vascular phenomena. What will be that vascular phenomena? That includes the Janeway lesions, that includes the conjunctival hemorrhages, that includes mycotic aneurysms, that includes the pulmonary, right, pulmonary infarcts. These are all the vascular phenomena. Next is the immunological phenomena. So the immunological phenomena, it includes the presence of glomerulonephritis, the Osler's nodes, Rod spots. Then lastly, microbiological evidence, right? Positive blood culture, but that does not meet the major criteria. So if one culture is positive, then that becomes the minor criteria. Then you need to be aware of certain syndromes called the Osler's triad or Austrian syndrome, which is caused by the Streptococcus pneumonia, where these patients will have pneumonia, they'll have meningitis, and as well as the infective endocarditis, right? So that is what is called the Austrian syndrome or the Osler's triad. Then what is the most common risk factor for the development of infective endocarditis is mitral valve prolapse with mitral regurgitation. And what are the factors which are high risk for the development of infective endocarditis is the aortic stenosis, aortic regurgitation, mitral regurgitation, presence of prosthetic valves, then tetralogy of Fallot, ventricular septal defect, right? So these are all the factors with high risk for the development of the infective endocarditis. Then what is the diagnostic criteria? Diagnostic criteria includes 2 major or 1 major plus 3 minor, right? Or the presence of all the 5 minor criteria, right? The presence of all the 5 minor criteria. So this will be the diagnostic criteria for the infective endocarditis. And at the same time, you need to know the organisms causing the infective endocarditis, like prosthetic valve endocarditis. So if the infection of the prosthetic valve is within 2 months, that we call it as early prosthetic valve endocarditis. where the organism is the Staphylococcus epidermidis, which is nothing but the coagulase negative staphylococci. 2 to 12 months, the organism is the same, that is coagulase negative staphylococci. And after 12 months, the most common organism that will be causing the prosthetic valve endocarditis will be the Streptococcus viridans. Okay, so this is about like the common organism causing prosthetic valve endocarditis. Then followed by that, Austrian syndrome we have discussed. Yes, so and what is the treatment in case of infective endocarditis is you need to give broad spectrum antibiotics, right? So you need to give 2 grams of ceftriaxone, and along with that you need to give aminoglycosides, has to be supplemented. So that is empirical treatment. Once the culture and sensitivity report comes, you need to give antibiotics accordingly, right? Then next question, the Osborn wave in the ECG shows the prolonged repolarization with a distinctive convex elevation of the J point, and these waves are associated with the systemic hypothermia, then acute pericarditis, acute myocarditis, and Brugada syndrome. So in systemic hypothermia, you have the presence of the Osborn wave. What exactly is the Osborn wave? It is also called J wave. So at the J point, you have the prolonged repolarization, and that is what is nothing but J wave, which is also called the Osborn wave, right? And you need to know what are the causes of non-hypothermic Osborn waves. Causes of non-hypothermic Osborn waves, that includes the hypercalcemia, right? That includes Takotsubo cardiomyopathy, right? That includes acute myocardial ischemia. So these are all the conditions like non-hypothermic causes for the development of the Osborn wave, right? And in Brugada syndrome, you will have coved ST segment elevation in V1 and as well as V2. And this particular Brugada syndrome is the one where the individual can have a sudden cardiac death, and that is because of the ventricular tachycardia and as well as the ventricular fibrillation. Okay, so that was about the Osborn wave. Right. So coming on to the next question, that is, we have a 28-year male patient suspected to have the hypertrophic obstructive cardiomyopathy. Which of the following statements are likely to be true on his examination? Maneuvers that decrease the LV preload will cause the murmur to intensify. Maneuvers that will decrease the LV afterload will cause decrease in intensity of the murmur. Murmur of the HOCM becomes softer with passive leg raising. Murmur of HOCM becomes louder with squatting. So in HOCM, the concept is very simple. What is the concept? If the obstruction increases, murmur increases. If the obstruction decreases, the murmur decreases. That is what is the concept in HOCM. Now, you take the first option. Maneuvers that will decrease the preload will decrease the LV volume, right? Will increase the obstruction and the murmur increases. That is the correct statement. Okay. And murmurs that decrease the LV afterload. The maneuvers which will decrease the LV afterload will increase the cardiac output. LV volume decreases, murmur increases. It will not decrease, it will increase. Okay. Then murmur of HOCM becomes softer on passive leg raising. Yes, on passive leg raising, venous return increases. LV volume increases. Obstruction decreases. Murmur decreases. Right. Then fourth option, murmur of HOCM, it becomes louder upon squatting. Remember, upon squatting, what will happen to venous return? Increases. LV volume increases. Obstruction decreases. Murmur, it becomes soft. Okay. So it will not be loud, it will be soft. So the correct answer here is 1 and as well as 3. Right. So that is about the dynamic auscultation in patients with the HOCM. Next question. Which one of the following is the manifestation of the vascular phenomena in modified Duke's criteria? So Osler's node, it is the immunological phenomena. Roth spot, it is an immunological phenomena. Glomerulonephritis, it is an immunological phenomena. Janeway lesions, mycotic aneurysms, these are the vascular phenomena in the minor criteria, right? Next question. We have a 60-year-old diabetic female presents with acute myocardial infarction. ECG changes include the ST segment elevation greater than 1 mm in lead AVR, the likely localization of the thrombus. Please remember, if AVR shows that there is depression, whereas other leads there is ST segment elevation, In AVR, there is ST depression, and other leads ST segment elevation. All other leads, that will be acute pericarditis. Whereas if the AVR is showing that there is ST segment elevation of by more than 1 mm, that is very much suggestive of left main coronary artery stenosis, which is very dangerous one, right? Very, very dangerous one. Whereas in right coronary artery, you will have ST segment elevation in 2-3 AVF, right? Whereas in left antidescending artery stenosis or block, you will have the ST segment elevation from V1 to V4. Left circumflex artery, lateral wall, 1 AVL, V5, V6, you will have ST segment elevation. Okay, ST segment elevation in AVR, that is very much suggestive of left main or the proximal LAD stenosis, right?